everyone, in this episode I interview Professor Alexander Heazell about stillbirth. If you enjoy these podcasts, please hit the like and subscribe buttons or visit iforgottooaskthedoctor.com. I'm Dr. Gail Busby and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Professor Alexander Heazell about stillbirth. Alex is a consultant obstetrician who has a dedicated interest in stillbirth. He is the director of the Tommy's Stillbirth Research Centre and runs a specialist clinic called the Rainbow Clinic for parents who have had a stillbirth in a prior pregnancy. He has extensively published and has won national and international awards for his work in this sphere. He is regarded internationally as an expert in stillbirth. I'm so pleased to have him on the show today. Alex, welcome. Thank you so much for joining me.
Thank you for inviting me, Gail.
So, Alex, I'm always interested to find out why distinguished colleagues like yourself chose the particular field of medicine in which they end up practicing. So can you explain to us why and how you ended up working in the field of stillbirth?
When I first came into obstetrics, I began to get really, really interested in why different pregnancy complications happened to certain mums, and they also happened to certain groups of women more frequently. And I decided I wanted to do some research, and so I came to look at really how the placenta went wrong in preeclampsia. And when I finished my PhD, I had a very good mentor, and they said that it's really important if you want to stay in research that you research something that you care about. And so I spent a long time reflecting both on my personal experience, on my professional experience, and felt at that time there really was a big gap in research that was specifically designed to prevent stillbirth. And so although I'm still really interested in what goes wrong in the placenta in specific conditions, what I really wanted to do was to prevent babies dying and improve pregnancy outcomes for both mums and babies.
Yeah, such really, really important work. So Alex, as you know, this podcast is aimed at educating patients. So as a result, we try to avoid medical terminology as far as possible so that it remains as accessible as possible to everyone. Okay. So Let's start with the absolute basics. Can you explain exactly what is meant by the term stillbirth?
So when we talk about a stillbirth, what we mean is a baby that dies before it is born. Now, depending where you are around the world, the length that a pregnancy has to continue before a pregnancy loss is called a stillbirth rather than a miscarriage changes. So there are some countries like the Netherlands and Sweden where that's as low as 16 weeks of pregnancy. And there are other countries where pregnancy is much less carefully monitored. So, for example, lots of sort of low and middle income countries where a baby wouldn't be called stillborn until it was at least 28 weeks of pregnancy. So in the UK, we sit halfway in between those, really. So our definition of a baby that's stillborn is a baby that dies before it's born after 24 weeks of pregnancy.
Okay. And can you give us an idea of how often it happens?
Yes. So the stillbirth in the UK happens in around 1 in 225 pregnancies continuing after 24 weeks. Okay. It changes in frequency over that time. So it's thankfully at the time when most babies are born after 37 weeks, it's lower than that. It's about 1 in 500 to 1 in 1,000 babies. Babies that are born nearer 24 weeks. It's actually a little bit higher than 1 in 225, partly because babies are so vulnerable at that early stage. So there's although it's 1 in 225, that's not the case all the way through the second half of pregnancy.
Okay. So not so infrequent, unfortunately. And as you know, I trained in obstetrics. I don't do obstetrics anymore, but I do remember that powerfully. It was the saddest part of my job, really, to have stillbirth. So it's really, really encouraging to have someone who is as distinguished as you working on this and helping women and parents who've had this tragedy before. What are the main causes of stillbirth, Alex?
So again, that's around the world, that changes a little bit.
Yeah.
So we know, for example, in low and middle income countries where about 94% of the stillbirths that occur around the world happen, actually, there it's about inadequate antenatal care, inadequate care in labour. So babies and mums can't be monitored as well as they should be. So in some regards, the solutions there are, we have those in our hands. It's about how do we roll them out? How do we make sure that you get universal maternity coverage of maternity care, for example? In countries like the UK or the US, so high income countries, essentially about 1 in 12 babies that are stillborn have a structural or congenital abnormality, so a problem that might be genetic or it might just be developmental. So the flip side of that is 11 out of 12 babies didn't have any structural problems. We'd have expected them to survive.
Yeah.
And then of those babies, roughly about half have a problem with their placenta. So the placenta is we also call it the afterbirth, but it's baby's life support system. So it gives baby its oxygen and its food, and it takes away carbon dioxide and waste products. It's a really important organ. And so when that fails, then babies can get very sick. And if it fails completely, then they can die. Then there's also problems with baby's cord. That can be a rarer cause of stillbirth. So babies can either get entangled in their cord or a true knot in the cord. And then there are other causes like types of infection that can lead to babies dying, either bacterial or viral infections. And sometimes the bacterial infections can happen when a mum's waters break, so the bacteria can get in from the birth canal into the uterus where there are not normally any bugs at all, and that can make both baby and mum poorly. Sometimes you can have other bugs like listeria, so sometimes some food poisoning, and that gets in through mum's bloodstream. So, and altogether, those causes account for about 4 out of 5 stillborn babies. Also, partly because we don't understand all the time why babies die, about 1 in 5 stillborn babies, after really sort of detailed investigation, will still not understand why they were stillborn.
Okay, so that's really interesting and so much information to get on with 5 minutes into this interview. So I always ask about risk factors in my podcasts because some things that you have mentioned, you can't really mitigate the risk. So for example, a cord issue where the baby somersaults, whatever, and there's a knot. A true knot is literally like a knot in the cord which cuts off the supply through the cord. There's no way there's nothing that you can do to avoid that. I guess infections as well, there's little you can do to avoid that. However, I guess there are some things that can decrease risks of certain conditions. some things I guess you can't change, like your genetics, I always say, but other things, there are lifestyle factors that sometimes you can modify to decrease your risk. So can you let us know what risk factors there are, and is there anything that women can do to reduce the risk of having a stillbirth?
So I think, just before I answer that, I think it's really important that we know that when mums have a stillbirth, they very often sort of take some of that blame on themselves. And sometimes that's because professionals haven't given mums the best education. But it's really important that I wouldn't want anyone to go away and think, oh, if only I hadn't done such and such a thing, then I wouldn't have had a stillborn baby. It's not as simple as that.
No.
But some of the things, kind of common sense things about mums being really healthy. So, can you optimize your health for pregnancy? So we know that stillbirths are more common in mums who smoke cigarettes. They're more common in mums who are extremely overweight, so have a BMI over 35. So we'd always say to somebody to try and optimize their health as much as they can before they're pregnant. When you're pregnant, I think the most important thing that you can do is to make sure that you have your antenatal care. You see people at the right time so that we can check your blood pressure, we can dipstick your urine, because that tells us whether you're getting preeclampsia, which is something that's associated with stillbirth. We and things like, again, getting the appropriate vaccinations, because we know there was a spike in the Delta wave of COVID, because that particular variant of COVID infected the placenta in some mums who weren't vaccinated. So definitely having your antenatal appointments. If you're asked to have a sugar test in pregnancy to see whether you have gestational diabetes, we know that if you do have gestational diabetes, which is when your sugar levels go up when you're pregnant, only when you're pregnant, then if that isn't diagnosed and treated, there is an increased risk of stillbirth. But if it is diagnosed and treated, there isn't an increased risk of stillbirth. So the important thing is getting the diagnosis made. And then other things in late pregnancy, we know that mums who go to sleep laid flat on their back have an increased risk of late stillbirth. So we advise everyone to go to sleep on their side. It doesn't matter what position you wake up in, but it's important to go to sleep laid on your side. So there's a number of things that we think mums can do that are quite simple, some that are potentially a bit more tricky, like smoking cessation, but there are services to help with that. So there are a number of things that we can do to try and reduce the risk of stillbirth.
Okay. And you mentioned earlier that really, I just want to emphasize the importance of attending antenatal appointments, because you're screened for things like preeclampsia. Preeclampsia you mentioned is high blood pressure in pregnancy associated with protein in your wee. So blood pressure is checked at every antenatal visit, and the urine is checked. Also, diabetes might be diagnosed that way with sugar in the urine, glucose in the urine on an antenatal check. So really, really important, really simple message. And you mentioned that there's a huge disparity in the rates of stillbirth between countries who have a good, well-developed antenatal system versus countries who don't. So kind of use the facilities and use the structures that are available to you.
And we know that even mums in this country who have fewer than the amount of recommended appointments, then sadly they also have an increased risk of stillbirth. So it isn't just the importance of having antenatal care in low middle income countries, but also in our own country. It's just
Absolutely. Okay. And are there any warning signs that women might look out for to think that maybe they're at higher risk during a pregnancy, or this is about to happen? Is there any advice you can give?
So in terms of, because about half of stillbirths in the UK are due to the placenta not working properly, that's why we measure the size of baby's bump, or you might be asked to go for additional growth scans if you're thought to be having a higher risk of having a small baby. So in terms of, so that's about detecting a baby that's not growing in the way that we think it ought to, at the speed it ought to. Also, we would emphasize to mums there's a whole range of warning signs that we would want to ring triage, so that the maternity department will have an access line 24 hours a day. And so if your baby is moving less than normal, if you've got bleeding, if your waters have broken, if you've got abdominal pain, all of those are important symptoms that we would advise you contact your maternity service to get checked out.
Okay, so any significant change that is worrying, have a low threshold to contact the department, because that's what we're here for, isn't it? That's what we're here for.
Absolutely. And thankfully, most of the mums who have those symptoms aren't having a significant problem.
Yeah.
But we can't tell that at the end of a telephone line. And we may need to put you on a baby heart rate trace to tell everything's fine. And if that's the case, that's great. We can confirm things are okay. But obviously, sometimes we do that, and there's a problem, and we need to act upon it. And that's why we have that triage system.
Yeah, okay. And likewise, if a patient comes in and maybe their bump measures smaller than expected at the antenatal appointment, then they'll be sent for further investigations. What can they expect in that scenario?
If your bump is measuring less than normal, that could be because it could just be the way baby is lying, but it could be that your baby is smaller than normal, or it could be that it has less water around it than normal. And both of those latter things can be because the placenta's not behaving as well as it should do. And so then what we would do is we would do a scan to check on baby's size and the water volume around it, and also usually the blood flow through baby's umbilical cord, because that tells us how well the placenta is working.
Okay, perfect. That you anticipated my next question. Is there any direct test to tell if the placenta is working well or not?
Yeah, so there's actually sort of a growing, one of the sort of things that's happening is that we're becoming much better at realizing that the placenta tells us a lot about how baby is. So as well as just looking at the end point of is baby big or small, and one of the challenges can be when you're doing just one growth scan, you can't tell whether baby's growing at the right rate from one scan. You can only sort of tell baby's growth from two scans, because you want to check that baby, growth is a rate rather than just how big you are. And so there's sort of, so for one example, to now diagnose preeclampsia much better, we use a blood test which tells us how well the placenta is working, using a hormone called placental growth factor, and that's come in the last 5 years. So I guess to stop the podcast being too dated, then I think looking into the future, I think we're likely to be able to offer more of those things.
Fantastic. That's brilliant. Okay. And so women who, unfortunately, this has happened to, how is the diagnosis usually made in your experience?
So usually what happens is mums feel that baby's not moving at all. So usually sort of absent baby movements. Or they may have other symptoms like bleeding or abdominal pain, and then they would come to hospital, and then we would do an ultrasound scan. And what we can do is we look to see that we can see baby's heart very clearly, and then to diagnose that baby's died, then obviously baby's heart wouldn't be beating. Because it's such a serious diagnosis, in the UK, that would need to be confirmed by somebody else, so that and I think sometimes mums, families find that really distressing, that somebody else we have to go and get somebody else to confirm that, but that is just because of the seriousness of what we're seeing. Sometimes on that first scan, we can see, sometimes we might want to measure baby. If we can see a really clear problem at that scan, sometimes we might ask permission just to very quickly take a picture or to make a measurement, because we think it's important in why baby has passed away. But usually that isn't the case, and we would just confirm that baby has died, explain what that means, what we're seeing, and that means that baby has died to the parents, and then try and answer their questions following on from that.
And cognizant of the fact that obviously it will vary, depending, I guess, on how far along the mum is and what the circumstances are around. What can families expect to happen next once a diagnosis is made?
So I think, in terms of what happens next, often depends on, it will depend usually on whether a mum has given birth before, and particularly whether she's given birth by cesarean section.
Okay.
Most times there are sort of two phases. We believe at the moment it's less of a physical impact. Mums get better quicker if they give birth normally. I think often people think obviously a baby dying is so abnormal. I think most people often ask me whether they have to give birth by a cesarean section. In our advice is usually to have vaginal birth, unless there's a very clear reason not to. So a mum was really, really sick, for example. We then use a drug called mifepristone, and that's a drug that it turns off all of the receptors that are keeping a mum pregnant. And we do that so that when we start labour off, that labour is quicker and less drawn out. The disadvantage, if we don't give the mifepristone time to work, when we start to induce labour, that can take a lot longer. And obviously that's extremely distressing for the woman and her family. So the downside of that is that mifepristone usually takes 24 to 48 hours to work. And I think that can be really hard. But I would say there was a study from Sweden that actually showed that almost half of parents really hated that drawn out bit, but the other half felt it gave them a little bit of time to get their head around things, and to make preparations. So, for example, if they had, they could tell family members what had happened, just get things together a bit. So that's sort of the first bit of what happens next. And then usually we would then advise having a few blood tests very quickly after the diagnosis. One of those blood tests is to look for, it's called a Kleihauer, and that looks for baby's blood in mum's blood. And that's because there's a rare cause of stillbirth called feto-maternal hemorrhage. So that's essentially just when baby's blood as baby's bled into mum's circulation, so we don't see any blood. And then we would also say to do a full blood count, just because we know then mum hasn't got any signs of infection, and also that her platelets, which are what helps your blood clot, are normal, so that if she then wants to have an epidural for pain relief, that we've got that on record already. So that's kind of what happens in the immediate aftermath. We also try and give people as much information as we can, ideally with some bits of it written down, because we recognise it's really hard to take in information at that point.
Yeah. Okay. And in terms, so once that process is complete, and the baby is delivered by whatever means, what about further testing? Will postmortems be discussed?
Yeah, absolutely. So we all mums and families should be offered the opportunity to try and find out why their baby died.
Yeah,
And it's a very individual decision about how much testing to have. But we recognise the importance of that. So we would normally recommend that the placenta go to be looked at under the microscope by an expert doctor called a pathologist. Usually we send a sample of cord to have a genetic test, because the cord comes from babies, so they have the same genetics. And we also look for, we may have a discussion about consent for a post-mortem. Increasingly, we're offering what we call non-invasive post-mortems. So we can do an MRI scan of the baby. And if we need to, we can take biopsies of particular bits of baby, rather than doing a sort of more traditional post-mortem, which involves having a cut on baby's chest and tummy and baby's head.
Okay. So that takes us through to what, how women maybe can try to decrease the risk, going to appointments regularly, if unfortunately the diagnosis is made, how it's made, what to expect, and that process. How is this information used? What happens in the next pregnancy?
So
Because I
actually,
think that's what people would really want after this podcast.
so the really important thing is then we gather all of that information together. Sometimes when we have that information, we then want to do more blood tests, because there may be other aspects. So, for example, if we see a placenta that has got lots of blood clot in it, and there's lots of areas where the placental tissue has died, then we might then want to see whether a mum has sticky blood, or another condition called antiphospholipid antibody syndrome. So then we may want to do some more bloods. And then ultimately what we need to do is we try and, the way I try and think about it is, we're trying to get all of these jigsaw pieces together to try and bring them back to make a picture, to understand why a baby has passed away. We should, when we do that, it's really important to have a meeting with the family and say, make sure we've answered all of their questions. All stillbirths in the UK have their care reviewed by something called the Perinatal Mortality Review Tool. So we need to feedback whether there were anything that could have been done differently, and have any lessons been learned in that mum's care. And then all of that feeds together into making a plan for another pregnancy. And that might involve having medicine like aspirin, or injections of a drug called heparin. It may be about thinking about when we would do scans to check for baby's growth. And then we try to make sure that the outcome of that appointment we put in a letter. And so we recognise that mums may not want to come back to the hospital where their baby died. They might want to go to a different hospital. But it's really important that whoever's looking after them understands why their baby died, what it died of, and what we're going to do in another pregnancy to make sure that that there's the greatest likelihood of a healthy baby being born.
Okay, so you run the Rainbow Clinic, which delivers the service to parents who have had previous stillbirths. First of all, are there similar clinics like that around the country?
So we're gradually scaling up the Rainbow Clinic. So we started off just with our clinic in St Mary's Hospital in Manchester. There are now 27 Rainbow Clinics in the UK. ranging from London. We have Portsmouth down on the south coast, Reading, through the Midlands up into the northwest where there are most of them. And we've also recently been working with a team in New York to open one in the United States, and also talking to people in India about how we adapt the model of care to work in that setting. So we're hoping that we can sort of spark a little network of these specialist pregnancy after loss clinics.
That's fantastic. That's wonderful work. And so patients who do come along to a Rainbow Clinic, can you give us an idea of how successful treatment might be? And I understand, of course, it depends on if any cause was found for the previous stillbirth. But overall, can you give us an idea of how successful it is that attending these clinics will decrease a woman's chance of having a subsequent stillbirth?
So sadly, we know that mums who have had a previous stillbirth are more at risk of complications, not just stillbirth in their next pregnancy, but other things as well. So mums, they're at higher risk of having a baby early. So there's before Rainbow Clinic, about 1 in 5 of our mums had a baby prematurely in a pregnancy after stillbirth. The risk of stillbirth was about 1 in 40 in another pregnancy after stillbirth. And in fact, as a single risk factor, when someone books, a history of stillbirth is the biggest thing. However, if you have specialist care, we've now managed to cut our preterm birth rate down to the same as the background population risk. So about 1 in 8 babies are born early, and the stillbirth rate is much lower than 2.5%. I think it's really important that nobody can ever promise somebody that something bad won't happen again, and we're always really clear with mums about that. But the outcomes within the specialist service seem to be much better than the general population outcomes we'd expect.
That's wonderful. Okay, so thank you for those clear and detailed answers to my questions. As you know, Alex, I ask listeners to submit questions before my podcasts so that I can then pose them to the experts. Are you happy for me to ask you some questions that have been submitted?
Yeah, absolutely.
Okay, so I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their current and past medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so the first question. It is widely accepted that 50% of parents who had a stillbirth experienced diminished fetal movements but delayed contact with the birthing unit. In light of this and understanding inequalities, is the current advice to expectant families to contact, accepted as meaning phone first, your maternity unit in the event of reduced fetal movement? Is this an unnecessary barrier that may make those most vulnerable hesitate or delay, for example, those with communication barriers? Should we consider changing the advice or language to walk in or immediately attend? For example, we wouldn't advise anyone experiencing chest pain to contact A&E first, but would say to attend without delay. I have asked this question many times, and I consider the answers received so far to be for the benefit of the unit capacity, sometimes cloaked in enhanced patient experience rather than the outcome. I would welcome your thoughts on what evidence is available on advising walk-in versus contact on the telephone on the incidence of stillbirth. So this question, I'll just summarize, is saying that should women who have diminished fetal movements, which, as you've said before, is a risk factor for having a stillbirth, should they just turn up to the department like A&E, or should we persist with the ring, get advice over the phone, and then come in if we think appropriate?
I think the first thing to say, I think that's a really good question.
Yeah.
And the first thing to say is, the person who asked the question said, what evidence is there? And one of the problems that we have is that the evidence about reduced movements, actually, the studies are still not really big enough to determine whether actually that acting upon that significantly reduces stillbirth. I think the question is absolutely right that we know there are some populations who don't present with reduced movement. So, for example, there was a study very recently from Stockholm that showed specifically their main migrant population there, which are Somali women, were 80% less likely to present with reduced movements. And when you looked at a specific analysis of a study that was done there, actually the education initiative in that group of women seemed to be more effective than it was in the background population, partly because I think they were reluctant to present in the first place. I think historically, often what happened when we were dealing much more with paper records, women were asked to phone the unit beforehand so their paper records could be obtained. Whereas actually now, as more and more and more hospitals are moving to electronic patient records, that's actually, that's less justifiable, I think. And I think we should be asking women. I think chest pain is actually a really quite a good analogy. Partly because like you say, if you see somebody in the street having chest pain, you don't say to them, "Don't go to A&E. It's almost certainly not a heart attack." Whereas often women, when they ask friends or family for advice about their baby not moving, may well be told, "Oh, I'm sure it'll be nothing. Don't worry about it." And equally, actually, a very small percentage of people who go to A&E with chest pain are actually having a heart attack. But you don't know that until someone's put an ECG on someone's chest and done a blood test about whether that's not happening. In the same way, we don't know if a baby is well until we've put the baby heart rate trace on and had a look and maybe done a scan or done some other tests. So at the very least, done a blood pressure and that baby heart rate trace. So I think there is a case actually for, as the questioner says, for not necessarily introducing a barrier. And I think it's also really important to recognise that other barriers exist. So, for example, we know that more women present with reduced movements later on in the evening, and that may be because that's when there's somebody else who can come home and look after the kids, and then they're able to go to hospital, because at 5 o'clock, when you've got your other kids and there's nobody else there, it may not be easy. So I think what we do need to make sure is to look in our triage departments where our busy times are and match our staffing to the busy times, rather than sort of saying, well, it would be convenient to us if you came between 9 and 5, because that's not the real world.
Yeah, that's a brilliant question, and it was matched by a brilliant answer. Thank you very much. Okay, my next question is, how long after stillbirth should one attempt to conceive again?
This is a really important question. I was really pleased to see that this had come up. Is that actually when you there was a really interesting study from the US that was published this year, and it showed that women are told a whole variety of different things, and actually we don't know why, so some mums are told, particularly if you've had a cesarean section, you're told to delay for longer. But
Yeah.
actually, there wasn't a relationship with how old a mum was or why her baby died. There's now really, really, really good data that compared if you conceived within a year of your baby being stillborn, between 1 year and 2 years, 2 years and 3 years, it doesn't make any difference to the outcome of your subsequent pregnancy. The only thing that I would say as a sort of a piece of advice is I would wait until you've got the results of your tests, because that will often, if we want to start treatment in another pregnancy, we need to start it early. And we don't want to be trying to play catch up in another pregnancy. So one of the things that we're trying to make sure is that mums and their families can get timely results and timely information so that we can go on and we can go on and
Make it count.
provide them with the best care. But in terms of this idea that people were sometimes said, "Oh, you should wait 18 months," it's not based on any actual data.
Okay, thank you. Really clear. The next question is, what is the most common cause of a stillbirth delivery?
So the most common cause in our setting would be that the placenta just isn't working normally. And so baby might be smaller than normal, or it may only have changes that we can see at post-mortem.
Okay. Next question is, my mother had a stillbirth. She does not talk about it, so I don't know why. And I guess that brings up other questions about the psychological side and whether these women have psychological support. But let me finish this question. I'm thinking of trying for a baby, but I'm a bit scared to try. Am I at greater risk of having a stillbirth because of my mum's history?
So the short answer is probably not, because the vast majority of stillbirths aren't related to genetic problems in baby. There have been some recent genetic studies that do show that daughters of mums who have a stillborn baby have a slightly higher risk of stillbirth, but this is likely to be mediated by the fact that she might also be more likely to be diabetic or have high blood pressure or have preeclampsia. So it's almost certainly not that there's an inherited condition that's being passed on to the baby, because of course that mum was born alive, but it may be that there are some complex genetic things that underpin that. So I think that really that emphasizes the importance of having good quality antenatal care, making sure that there's nothing like diabetes or high blood pressure that can be that we can treat and manage more effectively. But absolutely, I wouldn't, I don't want someone to go away thinking, this is something, I'm going to have a stillbirth because my mum had a stillbirth. That's not the case.
Okay. And again, it's about optimizing your own health, as you said in the beginning, as much as possible. The advice you give anybody, basically.
Yeah.
Okay. And the last question from my listeners, what is the concept of a rainbow child?
So I think that's a term that has kind of grown in popularity over the last maybe 5 or 10 years, and really describes a pregnancy after a loss. So sometimes people use it for pregnancy after miscarriage, sometimes pregnancy after a baby that has died or has been stillborn. And I think it's really just trying to emphasize, rainbows come at the end of a storm, and there's some sunlight and some hope. And I think that's where it comes from. It's not a term loved by everybody. I think, there are some people that warm to it, some people that don't. I think it emphasizes nicely that I think one of the really tricky things about stillbirth and bereavement after a stillbirth that you touched on before is it's often not talked about very openly. And if you have to go through another pregnancy. If to have another baby, you have to have another pregnancy. So that inevitably means some of those experiences you've got to repeat. And it might be having a scan in the same hospital. It might be seeing the same doctor. Those things are not easy. And I think, what we tend to see in mums in Rainbow Clinic is that mums kind of flip between this sort of, looking forward, hopeful anticipation. I hope it's going to be okay this time. And then, get pulled back to something more loss orientated and oh goodness, but then this happened again. And I think, a journey through another pregnancy is just a bit yo-yoing between those two things. And so I don't necessarily think a rainbow after a storm is a bad analogy for that.
Yeah, I mean, I think how you described it was quite beautiful, actually. I understand it myself now. Okay, so we've got one last question for me. So Alex, you have managed many patients so far who have had a stillbirth. Given the opportunity, is there anything that you would like to say to patients who have experienced this tragedy or who are worried about it?
I think the important thing to remember is that thankfully most pregnancies end well. When they don't, I think the most important message that I would say to all of the people I look after is this is not your fault. I think there's a huge amount of baggage people carry around with them, that they've done something, even from, I shouldn't have climbed the stairs so fast. Did I lift a heavy box? That this is not, this is not fault. This does not happen because you're a bad person. And that we really have to fight that stigma, and that with appropriate good quality care in a pregnancy afterwards, that the majority of families can go on to have a healthy, successful pregnancy.
Great, thank you. So in closing, Alex, I'd just like to thank you so much for coming on to the show and sharing your knowledge with us and doing that with such clarity. Thank you so much for supporting me in my efforts to educate patients, but mostly thank you so much for your years of tireless and distinguished work to the benefit of families who have had stillbirths in the past. Thank you so much.
Thank you, Gail, and thank you for including this as a topic on the podcast, because I think it's one of those things that sometimes just needs a bit more airtime and a bit more discussion.
Yeah, thank you. Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.